it can develop cancer. We don't catch cancer from outside. Cancer develops in the body itself when the cell is subjected to the risk factors and eventually turns into a cancer cell. So we can pass on risk factors, but we can't, because I wanted to show you risk factors are on the increase in this part of the world because also there's a transition in our physical environment. You can see Kampala in 1970 and then Kampala in 2016. The difference is big. The slums, that increases the spread of H. pylori, of course HIV, HPV. So the transition real puts us at risk of, 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 of cancer. I thought I had a slide on the shield. I wanted to talk about the shield. That 1 minute. Yes, because he's the one who asked me to talk about the shield. So I hope I will compromise him. But the shield is a new approved test by the FDA. FDA is Food and Drug Authority of the US that screened for cancer of the colorectal cancer, cancer of the colon and rectum, that you draw a blood sample and you look for the DNA fragments of colorectal cancer. Remember, we talked about the problem begins with the DNA. So you look for the DNA fragments in the bloodstream. Now, this is not recommended for people who are at high risk. It's recommended for people at moderate risk, because usually in the early stages of cancer, these fragments are not very prevalent in the bloodstream. So you can actually miss the cancer if it's very early. But it's very sensitive for advanced cancer. Actually, in advanced cancer, sensitivity is 83% and specificity is about 90%. But it's used for screening, but it's not very, very, very sensitive in early stage. Meaning, even then, you still need to subject this person to maybe some invasive tests. It's not yet here. Even in the US, it's not very dependable. So thank you very much for listening to me. I hope we'll be able to discuss during the discussion.
Thank you. Thank you. Thank you very much. Thank you very much. Thank you very much. Thank you very much, Dr. Mugisha. I can see you use some of my slides, so they must have traveled wide all over the place. So good student. Now, we need to talk a little bit more about the shield later on. But I was a bit generous with your time, and I gave you a little bit more time than I should. But I hope it was worth it. Now, our next speaker was supposed to be Dr. Fred Okuku, an oncologist at Uganda Cancer Institute. But he's unfortunately not able to be with us. So our next speaker is going to be Dr. Solomon Chibude. Now, I understand that you're going to stand in for Fred, correct? So you talk a little bit about the chemotherapy, but also you talk a little bit about your own topic, radiotherapy. So I'll give you a little bit more time to combine both presentation. So Dr. Solomon is a radiology oncologist in Uganda Cancer Institute. I recently was in the Cancer Institute about 1 month ago, and it was a far cry from the time when we were in Cancer Institute. The radiology unit is something to behold, really, if you went by. It has really good, very medical equipment. So I'm pleased that the oncologists are really now up at their game in terms of providing. I mean, not very long ago, we had to go to Nairobi for all this kind of treatment. So I'm really pleased by the kind of investment radiology oncologist has put in to be able to serve the people of Uganda. So Solomon, you have the floor, and I'll give you, you were supposed to have, between the two of you, you were supposed to have 21 minutes. So I'll let you have that. Thank you. Or you can use this.
Yes, I do. Thank you very much, Prof. Uh, all protocol observed. Good afternoon, everyone. In a special way, I would like to congratulate our guest of honor for getting to this day. Congratulations, Dr. Geofrey Musinguzi. So I would like to talk both on the aspect of medical oncology, and I'm fortunate to have trained first as a physician and worked in medical oncology for quite some time before I progressed into radiation oncology. Fred Okuku does agree with most of the content here and is caught up, couldn't make it. Whenever we have a patient before us, our conversation starts with a diagnostic pathway, and there we take a comprehensive history and a physical exam, and we often look at the laboratory workup. We review their pathology, imaging, and most importantly, we discuss amongst us as colleagues in the setting of a multidisciplinary team, because we know such a team offers the best outcome. And I'm very happy to be part of this panel, which is multidisciplinary in nature. Thank you so much to the organizers. So the first, when we have a patient, specifically with rectum cancer, we often consider radiation as a key treatment modality. And when we dialogue with the patient, the first thing to consider is the aim of the treatment. And then we look at the facility where we are practicing, what are the equipment available, the experience of the team, because it's a teamwork. And then we look at the patient. First, the tumor, what type of histology are we dealing with? Where's the location? Is it likely to respond to radiation? And lastly, we look into patient factors, whether they are able to undergo the proposed treatment. One of the most important parameters we're very careful about is the stage. And again, the stage with reference to cancer essentially refers to how far the cancer has moved from where it started from. We often look at the tumor, the primary, and then we look at lymph nodes. Those are glands that drain the site where the cancer starts from. And then we look at far places from where the cancer starts from. And using that information, we are able to come up with the stage of the cancer. Once we have the stage, then we look into the goals of care. In the management of rectum cancer, the primary goal is to ensure a low risk of residual disease. We want to eliminate all the disease as much as possible, because we know that whenever there's any residual disease, there's a risk for local recurrence. Secondly, we are cognizant of the normal function of the rectum. The rectum helps to keep the stool for quite a time until we are able to reach our places of convenience. So we're very, very cognizant of ensuring that we preserve the sphincter. We ensure a good sphincter function after the treatment. Now, based on the staging, we often have 4 groups of this type of cancer. We can talk of very early, intermediate, and then locally advanced. And later on, we talk about metastatic rectum cancer. And as you see in the subsequent slides, the approach to treatment has multiple options. So often it can be very confusing. For the very early surgery plays a key role, and that I'll leave to the colorectal surgeon in the house. Usually for intermediate and advanced, that's where radiation and chemotherapy play a significant role. Besides that, there are other aspects that are important. There's a moving trend towards organ preservation. We are trying to see whether we can bypass the surgeon without surgery in the form of organ preservation. And there's a lot to look at in terms of response assessment and the approach of giving treatments after surgery up front is mostly outdated. At the moment, we often encourage a total neoadjuvant therapy approach, which refers to giving all the chemotherapy and the radiation up front before surgery. And with this approach, we are able to introduce systemic treatment early on, which helps to control the risk of cancer or micrometastasis, cancer cells that could have seeded into the body. This approach also increases the chances of a complete resection without any residual disease. We also improve the chances of early reversal of a stoma, as the surgeon will mention, and we optimize patient selection for organ preservation. However, the drawbacks is that some patients might be overtreated if you give all the chemotherapy. Some might not need that. And there is a potential for early progression that could make surgery more difficult. When the cancer progresses to metastatic, again here, patient must be discussed in the setting of a multidisciplinary board, tumor board. We look into several factors such as the age, comorbidities, preferences by the patient, the extent of the primary and presence of metastatic disease. And often we want to start with some local treatment, often radiation, followed by systemic therapy. And here we might do several tests to define the biology of the cancer before we encounter treatment. At the moment at the Uganda Cancer Institute, our first-line treatment with chemotherapy is based on infusion, but also a tablet form of treatment called capecitabine, and we might use the combination. After treatment, this phase is followed by surveillance. In surveillance, we're trying to do checkups to make sure that the patient is free of cancer. And we do this both in form of history taking, physical exam, imaging, laboratory assessment by checking the carcinembryonic antigen. The shield is not yet a standard of care, but also colonoscopy. And we do this collaboratively between the radiation, medical, and surgical oncologists. Ladies and gentlemen, that was a brief overview about colorectal cancer. I would like to dive into specific aspects of the facts and the myths surrounding radiation and subsequently about chemotherapy. Now, radiation, as you all know, is a clinical modality that deals with the use of ionizing radiation for the treatment of both malignant but also benign diseases. So over 85% of our patients might have a cancer, but some 15% might have a benign condition that is having a malignant potential, often by its location and its risk associated with it. The overall goal is to either cure the cancer, control growth of the cancer, palliate or relieve symptoms for as long as possible, and reduce the risk of cancer returning. And the radiation has got different types or modalities. It can be delivered from outside the body, and these are the machines now available. This is a technique called external beam radiation. It can also be delivered from sources inserted inside the body cavities in a technique called brachytherapy. We can also deliver it during the operation, something called intraoperative radiation. Over time, radiation has been evolving from the early 30s, early 50s, from 2D to 3D or three-dimensional radiation therapy towards intensity modulated radiation therapy. And as you can see, it gets more complex with time. And even now, it's getting complex every other day. Today, people are using proton therapy, which has minimal side effects, minimal that you can walk away without any much side effects of treatment. In other parts of the world, they use carbon particles, and now some centers are using flash radiotherapy, which is extremely new. There are some important facts that we need to know about radiation, and these baffle a lot of people. Radiation is given on weekdays, designed to give a patient a break on a daily basis, at least 6 hours apart before subsequent treatment, and at least 2 days of a break. I know some people would like to take their treatment Monday to Monday, but we like it Monday to Friday. Secondly, patients may have 1 or up to 35 or more sessions of treatment. And for rectum cancer, it's often about 28, but we're trying to bring it down to a week course of treatment. Sometimes we do shielding in the way the patient is set up, and we work as a team, and we have therapists who are in the room or just at the control room to deliver the radiation as it has been planned. Now, there are several processes. It all starts with an appointment and deciding that there is an indication for radiation. And then we go into planning, which can be very conventional using X-rays, or can be complex using a CT scan, or even more complex using PET-CT, or even MRI. And then we find the best way to deliver radiation with maximal dose to the target and minimal dose to surrounding normal structures. And then we deliver radiation over weeks, often with concurrent chemotherapy, depending on the tumor type. And then we do follow-up. And these processes are complex. They might take, up to 2 weeks to prepare a good radiotherapy plan before you deliver. So it's not a walk-in and treatment starts to happen. Behind the scenes, we have a team that includes physicists, therapists, biomedical engineers, and nurses, all working to ensure that the treatment goes on successfully. Despite the goal to eradicate cancer, it's not without side effects, and these can be general, such as headaches, fatigue, hair loss in specific sites of the body, soreness within the radiation field, nausea and vomiting due to cytokines being released, and diarrhea. And they could also be very specific to the site that is being treated, as shown on the slide. When these side effects happen, we do encourage patients to ensure a balanced diet, to keep well hydrated, to keep positive, because the risk of terrible side effects, that is requiring an admission, is kept below 5% for most of our treatment. And we make sure it doesn't go beyond 5%. So the risk of death during treatment attributed to radiation is extremely low, less than 1% for most of the time. During treatment, we might administer concurrent chemotherapy. Chemotherapy is used to stop cancer cells from growing and can prevent cancer cells from spreading. And there are different medicines that we do give. They are not without side effects. Some of the common side effects you include nausea, vomiting, sores in the mouth, fatigue, the risk of infection, and most of these are manageable. In conclusion, in the approach to colorectal cancer, there are several pathways that we can take. We have multiple sequences, sometimes surgery upfront, followed by chemotherapy and then radiation, sometimes a combination of chemotherapy with radiation and then surgery, and sometimes chemo, surgery, and adjuvant radiation. And all these are designed to ensure optimal outcomes for patients with colorectal cancer. Thank you very much.
Thank you very much. I know it's a long story and somewhat complicated, but thank you for quickly taking us through this. Our next speaker is going to be Dr. Zhang. He is a colorectal surgeon from the Korea International Cooperation Agency. I was chatting with him while we were waiting to start, and I was very surprised that Dr. Chang has been in Uganda for the last 8 years working on colorectal cancer. So you're welcome to give your presentation. About 5 minutes.
Yeah. Thank you very much, Mr. Chairman, for introducing me. It's an honor for me to be here to present about the colorectal cancer surgery. And then congratulations, Mr. Dr. Musinguzi, Geofrey, and the family for writing about the journey of the colorectal cancer from diagnosis and then to the recovery. However, your journey doesn't finish, it's continuous. We usually follow for 5 years at least, or sometimes for 7 years. So, so I didn't make the slide like an academic conference, so don't worry. I will just present very easily. Also, we have surgical options for the colorectal cancer surgery. The right one is open surgery. That is the very common in the Uganda and Africa. That is the normal one. We just incise the abdominal wall and operate. And the left two, those things are the minimally invasive surgery. There's a laparoscopic surgery and a robotic surgery. However, unfortunately, we don't have a robot yet in Uganda. However, we are doing laparoscopic surgery since 2019, and our outcome is not bad, it's good. So open surgery, as you see, we just open and we see the organ directly with our eyes, and we operate by the retraction or pulling and then retracting like that by the hand or the instrument. So sky is like that somehow wrong because sometimes for rectal cancer, we need to mobilize splenic pressure here because otherwise the bowel doesn't come down to the anal area. So as you see, incision is very big. It's not good for the cosmesis, plus the surgical trauma is also somehow high. And this is a laparoscopic surgery. So we usually incise 4 or 6 trocar. For the trocar, between the 5 millimeter and 12 millimeter. So we operate using the instrument for laparoscopy, and we see the camera. So there is the right side, there is the wound. As you see, wound is very minimal. So surgical trauma less, so it's better, it's very good cosmesis plus early return for recovery to the work or to the daily life and then everything. However, because for the cancer surgery, most important thing is oncologic outcome. However, already is proven internationally for the colorectal cancer surgery, same oncologic outcome between open and laparoscopic surgery. If the surgeon is familiar with the laparoscopic surgery well. Totally remove the right side. We are calling right hemicolectomy or extended right hemicolectomy. If cancer is left side, descending or splenic pressure side, we usually do left hemicolectomy. If a cancer located in the sigmoid colon, we do sigmoidectomy or anterior resection. It depends on the cancer location. And if the cancer is in the rectum, we can do anterior or low anterior or ultra low anterior. Dr. Musinguzi underwent ultra low Ultra low means we anastomose in the anal canal. It's usually anastomose is between 2 centimeter from the anus. So it's very close. Yeah, it's very demanding procedure. And then if there is a synchronous means you have a left side colon cancer, right side colon cancer simultaneously. Sometimes we remove subtotal or total colon, or sometimes colon plus rectum. So those are different types according to the tumor location. Of course, unfortunately, when you do surgery, there is a complication or side effect. So basically, there is a bleeding, there is an infection, surgical site or the inside abdominal wall, or infection happens in the anastomosis. So sometimes anastomosis is broken down. And then there is a complication associated with anesthesia. So we can have an infection in the lung. Sometimes you can have some dysfunction in the liver or kidney. And then also when you do the surgery, adhesions comes. So because of adhesions, sometimes we have ileus. Ileus means the bowel doesn't move well. So mechanical ileus can happen. Also sometimes the functional paralytic ileus. And then according to the patient, the comorbidity, we can have a cardiovascular dysfunction. Sometimes the cancer patient has hypercoagulability. That means the venous clot comes easily. So because of that, sometimes deep vein thrombosis, the leg swells, or sometimes those clot goes to the pulmonary, the vascular system, and the patient respiration drops down and the saturation drops down. We are calling it pulmonary thromboembolism. Those things. However, in Uganda, when I observe, surgical site infection is somehow common. And then because the other things is not very common. And when you put I don't know, Musinguzi will say, when you put a temporal ileostomy, sometimes because of the operation and then bowel movement on and off some ileus and then difficulties. Yeah, those things. So Dr. Solomon said, so after surgery, we give to the pathologist our specimen. Specimen means the bowel will resect it. So they are seeing how deep the cancer invaded the wall itself. We are calling it T stage, or it invaded the adjacent organ or not. And then we are seeing there is a lymph node whole our body. So they are seeing the lymph node, there is a cancer cell inside or there. Another thing is there is a metastasis. The metastasis means the cancers are going far, like liver or lung or the peritoneum, the thin layer in the abdominal wall, far area. So they are deciding stage 1, 2, 3, 4. So according to the stage, we decide we'll do adjuvant chemotherapy. Adjuvant means post-operative chemotherapy or not, or we'll just observe the patient or not. So this is the America data anyway. So cancer registry usually say left side is colon cancer, overall survival, 5-year survival rate is 63%, localized. If it doesn't go somewhere else, or lymph node is negative, 73%, 91%. If it invaded the adjacent organ or lymph node positive, 33%. If there is a distant metastasis, 30%. Rectal cancer over 67%, localized 90%, regional 74%, distant 18%. So as you see, the result is not bad. So important thing, we'll discuss more early diagnosis, and then we can intervene. So I think that we have some more discussion time. So I think for the colorectal cancer, we have a very good team for chemotherapy, very good team for radiation treatment, and a very good team for surgery. So I think because our center is very good, I think I don't know you guys visited our Mulago National Referral Hospital Center endoscopy, laparoscopy surgery center or not. However, I swear we are the one of the best in East Africa. Only our the challenging team is only the South Africa now. So don't go to Nairobi, don't go to Kenya. We can do for the colorectal cancer surgery for everything. Actually, we are doing every colorectal cancer surgery laparoscopically, if it's possible, if it's not advanced too much. Yeah, thank you very much.
Thank you very much. That's very encouraging. That's very encouraging. And lastly, we are going to hear from Dr. Frank Mugabe. What more needs to be done?
Thank you very much. I'm Dr. Frank Mugabe. I'm a principal medical officer in the Department of Non-Communicable Diseases. Congratulations, Geoffrey. I met Geoffrey during the SPICE project in Mukono. And I want to appreciate him for accepting to share his story so that all of us can learn from it. And as Minister of Health, it's going to give us mileage. And I'm sure all of you who are here, you have already learned a lot from it. As Minister of Health, of course, cancers are one of those biggest issues that we are dealing with. For starters, we think that the first priority is to close the tap as much as possible. Prevention, prevention, and prevention. We have listened about the surgeries, but we can do as many surgeries, we can do as many what? We can have as many people walking to Cancer Institute. Need to try as much as possible, practice prevention. And what more are we doing? We are working towards integrating cancer prevention into existing services. We now know, and we have known, that the risk factors related to cancer are shared with other non-communicable diseases. I think Dr. Noble was quite eloquent about that. Alcoholism, you know how rampant it is. So what more can we do? Awareness and behavior change. Physical inactivity, I'm sure we who are here, we have learned of how important it is. What more can it do? Spare time and practice physical activity. I'd wanted to make you stand up and shake, but I know professor's time is strict. But physical activity is very important. Keeping a healthy weight is your responsibility. So the more to do is with you, with me. Let us avoid infectious diseases. HIV is one of those propagators of cancers. HPV is another one. H. pylori is another one. There are lots of toxins. They have talked of environmental degradation. In most cases, all of us indirectly contribute to environmental degradation. That's part of what more we can do. The other one is early detection. Once we have understood the importance of early detection, then we will go for screening very early. I hope Geoffrey will share with us his story, but some of these conditions are asymptomatic. By the time you start seeing the symptoms, it will be almost late. I was asking someone if he has ever done a colonoscopy, one of my colleagues, and he said no. But I also remember one of our colleagues, when he went for a colonoscopy, he actually found that he had cancer of the rectum, stage 3 or 4, and he's long gone. So should we fear to do some of these things? No. The Ministry of Health is thinking of decentralizing these cancer screening services through the Cancer Institute. The cancer center is coming up in Guru. A cancer center is coming up in Mbarara, Arua, and I think Mbale. For other cancers like cervical cancer screening, we have already spread cervical cancer screening to almost every health center 3. What is failing us are the people not showing up for cervical cancer screening. So we need to create more awareness. Childhood cancers, most of them are not associated with these risk factors. So early screening is the answer if we are to detect childhood cancers. And they are also quite many. When you visit the Cancer Institute, you are amazed by the numbers, over 200 plus per year. And when you find them, they are treatable. Early diagnosis and treatment. I think you have heard from Dr. Chang and Dr. Solomon. If you are diagnosed early, chances of surviving are very high. But they cannot diagnose us early when we are not presenting ourselves, when we are not routinely checking. So we need to work on those. So diagnosis and treatment, they go together. Government is planning for decentralized treatment through those cancer centers. In the same vein, government is also expanding work at the Cancer Institute. There's a lot of construction going on. If you have passed on that hill, the Cancer Institute is being transformed into a regional center of excellence. It will do a lot of work, as I said, but most of the work might be palliative work. This is the truth. So we would want us to do everything possible to prevent. Government is partnering with various stakeholders. Some of these interventions are not specifically Ministry of Health, but we need all other sectors to become a part of this. And the Cancer Institute is one of those arms of government. I want to conclude by saying that cancer management is very costly. Very, very costly. I think you heard Professor Rhodes talking. This, what could have happened to Geofrey does not happen to an ordinary Ugandan. Therefore, cancer being a catastrophic condition and having, in most cases, bad outcomes, especially because people present late, and it's also called late, we need to intensify efforts of awareness. We need to intensify efforts of early screening, early diagnosis, if we are to change the tide. And that responsibility is with us. As Ministry of Health and Cancer Institute, the number of documents we work on. For example, we are about to finalize a national cancer control plan. This is a very, very complex document. I personally don't understand it, though it has been presented several times. But beneath it, there are other specific plans like the cervical cancer plan and the guidelines and other plans. And we are looking at integrating some of these interventions. So the responsibility is with us. Let us support government to make sure that we prevent these cancers. Thank you very much.
Thank you very much, Frank. I think he saw me stand up. Thank you, Frank. It's 2 minutes past 4. We started late, but I would like to quickly get us back to the program. However, I think there's something that's something that needs to be emphasized. I think, Mugisha, in your presentation, you spent a lot of time talking about what is cancer. And I must admit, we didn't spend a lot of time on early diagnosis and treatment, which is really the Achilles heel here. I mean, that should be the main takeaway. How do I prevent or to catch this cancer fairly, very early? And in the interest of time, I would like to give you again the microscope to tell the audience what is the take-home message for screening and early diagnosis. Take us through the ages in this room, the 30s, the 40s. You know, cancer, we used to think of colon cancer in the late 80s. In fact, when I heard of Geoffrey's story, my first question was, he's too young. We never used to see cancer this old. When should we start screening? How often should we screen? What are the screening options we have? I think that is a very important takeaway message, and we didn't spend enough time to giving the audience here. If that is the only, if one message that is critical, that's the takeaway message. And I would like you to walk us through from a 10-year-old or 15-year-old in terms of prevention of cancer of the colon. And be brief.
Thank you very much, Prof. I will start with children. He said a person of 10 years. At Uganda Cancer Institute this year, we expect to receive over 700 children with cancer. Now for children, as Frank said, there are no known risk factors that you say, let me avoid this, that. We want all children, if they have any illness, make sure you see a right medical doctor. There are many wrong medical doctors in Kampala. Frank, you bear me witness. Even if you cross the road, you'll find somebody who claims to be a doctor. So every illness in a child, make sure it's well evaluated by a qualified health worker. That's bottom line. But for children, usually the commonest cancer in children generally is leukemia. But in Uganda, our commonest cancer now is leukemia, but we used to think it was lymphoma. So if a child has any swelling, make sure you know what it is. Go to the right health worker, go to Mulago, for instance. Make sure you know what that swelling is. If a child is not growing, make sure you know why they are not growing. Let it not be they have an infection and they have a cannula, they are moving around with it. That's for children in general. Now for young people, generally speaking, teenagers, they also suffer from cancers, but we do not have screening approaches for them. But we want to make sure that they seek the right health care. For instance, there is no reason why a young person should have headache all the time. It could be migraines headache, and maybe,
Excuse
but,
me, I like to be specific to colorectal cancer. Yes.
Thank you very much. Colorectal cancer. I will switch immediately. Now, for colorectal cancer, we don't have screening approaches for people who are below 40 years here in Uganda. But for everyone who is above 40 years, we want to screen them for the disease risk, family history, body weight, and also lifestyle. I mean, qualified to have some tests. We don't call these screening tests. We evaluate them on history and physical exam, and we choose which tests to do for them. Because we do not have screening tests are those you do for everyone to look for disease, the way you go to a village and screen for HIV. Now, for colorectal, to have an opportunity to be evaluated so that we screen you for the risk. Now, majority of the people will not say they are at this risk because many Ugandans don't know their family history. They don't know what their parents died of, their great-grandparents. But at least we are able to know your lifestyle. You know, what you eat, whether you exercise or not, and then take your body weight. Now, for those who are above 40, again, we screen them for their risk. And then the test we do here is fecal occult blood test. We get a blood sample, we look for blood. Now, that usually really detects cancer that is already causing in the bleeding in the intestines. So it's really not what we should celebrate about, but it's what we have here. And then those who have family history, we are able to recommend they do a colonoscopy that Frank was talking about. Now, colonoscopy is again not affordable to every Ugandan, but I want to imagine for majority of the people in this room, it's affordable if we recommended it. I want to say that if my, so again, it's us as individuals saying, I am not at high risk, but I can afford to do these tests. So at the Uganda Cancer Institute, when you come for cancer screening, because the cancer screening clinic is for everybody, when you come, we assess your risk, and then we tell you the tests we can do, and we do those tests for those who can afford colonoscopy, for instance. For the fecal occult blood test, we do for everybody. But I want to tell you that when it comes to colorectal cancer, we do not have any robust screening program for it in Uganda. It's really case by case. I don't know whether that answers Professor's question. I can respond to individual questions, but when you come to my clinic, I will evaluate you, take your family history, measure your body mass index, take your history, the food you eat, and then I will say we can do colonoscopy for you, but we can do fecal occult blood test for everybody.
To inform the audience, there are general guidelines on what age you start doing colonoscopies for screening and how frequently. I think people should leave here knowing that routine colonoscopy at particular age and particular frequencies is something that is highly recommended. That's the kind of thing I want.
Professor wants me to state like the guidelines of the US. But when I'm speaking here as from the Uganda Cancer Institute, speaking on behalf of government, I am not going to recommend the guidelines of the US. I'm telling you, everyone who is 40 years and above, present yourself for screening. Now, we will not recommend annual colonoscopy, but we recommend the frequency of colonoscopy depending on individuals. And I really want that to be very clear, depending on individuals. So each one of us should present themselves for checkup. Then we'll recommend. Now, I could say, for instance, Musinguzi's brothers, we recommend colonoscopies every 3 years, not every year, because it's expensive and it's probably not necessary for them. But when they come, we also do the other, fecal occult blood test. And I don't know whether that is clear.
Why only the brothers? Why only
because they are high risk.
Not
he has a
the
history.
sisters?
No. I was picking brothers as an example. I should have said family members.
Okay, thank you very much.
I should have said family members. But because we do not know the family history for everybody, we don't have a blanket recommendation. And because we know that the services are not available.
All right.
Yes.
Mugisha, thank you very much. I would have loved to ask some more questions, But in the interest of time, I would like to open it up for any 3 or 4 burning questions from the audience to any members of the panelists. Please, we'll have the microphone. Probably we'll take 2 back to back. Please indicate your name, where you're from, and then to who your question is.
Thank you. My name is Lucia Orikiriza-Bariho. I'm a survivor. Spitable bones, but they said it was TB of the bones. But I already had a tumor that was discovered when I had already reached India. Secondly, the radio,
Is it a comment or a question?
a question to the Ministry of Health
Okay.
and also to the team at the Cancer Institute, because sometimes you find even for a monitoring test, you have to buy a ticket if you can afford to go overseas for the test. Secondly, on radiation, currently the numbers are sagging every day, even when we go to the Cancer Institute for radiation. You find sometimes you're struggling with cancer, but you have to be there as early as 5 a.m. so that you can beat the line.
Oh.
So are there efforts of decentralizing some of these diagnostic machines? And we will be happy also to know how the government is working on this. Cancer ate my bones, God preserved my spirit.
Okay. I'll take a second question. I think those questions, I'm sure Dr. Frank has noted them. Any other questions? Yes.
Thank you so much. My name is Kwizera Christopher. I head Uganda Non-Communicable Disease Alliance. It's a civil society organization that coordinates CSO's efforts to fight non-communicable diseases. Before I pose my question to Noneba and Frank, I stand here with a heavy heart. Dr. Noneba presented risk factors, and he alluded that the major risk factor to cancers is alcohol. 2 days back, the Parliament of Uganda connived with the Attorney General, I should speak that, and murdered the alcoholic drinks control bill that was supposed to regulate alcohol consumption in the country. And they, I don't know, the reasons they brought forward were that it was affecting the economy, of the bill would affect the economy of the country. And of course, not about somebody who arrives from family medicine and somebody with public health. Do we need money first or do we need health first? And of course, that's why I say I'm with a heavy heart. As I speak now, the Attorney General and the Parliament declares Uganda an open bar at any time, everywhere, for everybody. So we do not have a law that regulates alcohol consumption in this country as I speak. And it's a problem and it's a catastrophe. So Frank and the neighbors, you come from government, you should be able to save that. Now, the next question goes to Dr. Noreb. You tried to explain and say that we do not want to do colonoscopy because it's very expensive, and also said that you would look at the relatives of Dr. Musinguzi in that family because we are not sure of our family history. Not too long ago in this year, this country has declared a lower middle income status. And I think we should be taking advantage of that. And then we think that should recommend that people who get to the facility should be able to should access the services as and when they should go. Then the other question is, if all Ugandans who are eligible for the service walked to your cancer institute, will they get the service? Would you be able to serve them? Thank you.
Thank you. I think let's stop it at that. Let's have Frank start off, and then Mugisha. Decentralization of services, PEPS card.
Thank you very much. I think the PET scan, Dr. Solomon will say something about it. But regarding decentralization of services, I must say it's work in progress. Like I alluded, we are going to have a regional cancer center in Iguru. We are going to have a regional cancer center in Mbarara. And we are going to have a regional cancer center in Mbale and Arua. But you know, government things. You need to be patient. We need to be patient. There are many things we are patient about, including going to heaven and meeting Jesus Christ. So we need to be patient and work towards the prevention. That's how I want to end that. For alcohol, Chris, my friend, lack of a law does not open you to go and mess up yourself. I think that's all I can say. If there is no law against alcohol, is it a free ticket that you should drink yourself crazy? Our work is to create awareness. If you are aware, there are many things that trap us every day. But do we do them? If we create awareness and you know that alcohol is not only a bad, it's an evil. They have not even talked of cancer of the esophagus, by the way. Larynx, what, very highly associated with alcohol. So, lack of a law, yes, I know the ministry will respond. That's not my mandate. But it doesn't mean that we should. Really, that everybody should go and mess up and drink day and night because
Okay. All right.
there is lack of a law.
Well,
Please talk.
PEPS card. I
Thank
know a
you.
lot of people who have to go to Nairobi to get a PEPS scan. It's quite a cost.
Thank you, Lucia, for the question about a PET scan. I'm glad to inform you that construction is underway. Already, the contractor has been identified and construction is underway. And besides the PET scan, there is a SPECT CT, which is another nuclear medicine
Yeah.
technique
Mhm.
that is going to be operational most likely before October this year.
Yeah. Oh, wow. That's nice.
It helps a lot in improving diagnosis and follow-up and picking up occult cancer hiding within the body. In terms of radiotherapy, in line with what Dr. Frank has said, to every site where there's going to be a regional cancer center, phase 1 is chemotherapy, then phase 2 is radiation. And I'm glad to inform you, already there are plans to set up radiotherapy at Gulu and then Barara and so on with every regional cancer center that is set up. So already government knows about this problem and wants to spread the services across the country. But equipment alone is not enough to deliver a radiotherapy service. One of the key ingredients is training. Training an oncologist takes 4 years post initial training at the master's level. So we're again glad to inform you we have a fellowship program and we are having a second training starting September, and it will take another 4 years to release. And we have maybe 2 other trainee Ugandans out of the country. So human resource is important, but there's a training now available for people who are interested in this science to take, to provide services. Besides government, there's work in private, not-for-profit, as you know, Cancer Run and so on. St. Francis Hospital in Zambia is in advanced stages of setting up a center. Aga Khan has joined the private sector. We have plans to have a pet city, and so on and so forth.
All right. Thanks
Thank
very much. One last, we will, Dr. Musinguzi will talk about can we do colonoscopy whenever present himself.
So thank you very much. In the interest of time, I am not going to move there. As I said, and listen again, that there's a criteria for somebody doing endoscopy. You don't, when you come and you say, I want endoscopy, and you're 15, we will really educate you that it's not going to be necessary for you. But I want to tell you, if any of us here came for colonoscopy, we will do it for you. Now, it doesn't mean that if every Ugandan walked in, we will do it for them. We would have to evaluate and see whether it benefits or not.
Okay.
Colonoscopy in New Mulago costs, I think now it's 300,000 Uganda shillings. Colonoscopy is 400 Uganda shillings. Now, we can afford it, but not everyone can afford it, every Ugandan. But I want to encourage you that our regional cancer center in Barara has been in operation. We have 21 beds. We run an inpatient service.
Right.
We run outpatient services every day. So people from Western Uganda, many of them don't have to come all the way to Kampala for treatment. But as Solomon said, the Guru Regional Cancer Center is operational. We only provide some cancer prevention services. We hired staff for it. We are training them at Uganda Cancer Institute. So it's a process because cancer is a specialized oncology, is specialized services. You don't just hire a doctor and tomorrow they provide radiotherapy.
Right.
Solomon spent many years in South Africa to come to become a radiation oncologist. So that's important for professor and dean for the university,
Okay.
that we need to partner and make sure we have human resource.
Thanks.
Thank you.
Who of you takes, we call it a tipo in the evening? A drink. Hands up. I'm sure there are more hands here. I have been reading with a lot of trepidation in this week on the new data on alcohol and cancer. And they were analyzing all the old data that showed that a glass or two of wine is good for your heart diseases and so forth. It turns out all those were flawed analysis. And actually, the American Cardiac Association, the American Cancer Association, the Canadian Medical Council have all revised their recommendation on alcohol. Alcohol is bad for you. And I actually drink every day, but alcohol is bad for you. I mean, the data was so sobering. However, when you read The Economist, to the gentleman's question, the quickest indicator for economic boom in Africa is what we call BBC, beer, banks, and cement. If you look at the sale of those three, or how prosperous those three indicators are, it shows good revenue for the ministry. And beer is actually a big earner for government. So I can see there's a huge dilemma here. But I think Frank's response to alcohol is a personal responsibility. And this is part of the education this whole session is all about. I would like, in interest of time, to close it. But before as I do, I'd really like to echo, add my voice to all the previous speaker, that Geoffrey really has done us all a favor. Not only he's going to share his experience, but also to give us a platform to educate people who are here online about this disease. Colon, a lot of people are dying from gastrointestinal cancers. Dr. Mugisha may not have told you that many cells that have a potential of really multiplying very fast, like gastric intestinal lining, it has cells that divide very quickly, naturally. They tend to be very prone to cancer or cancers of the liver, or a cell that tends to regenerate. So it is a fairly much more common as we get to diagnose more of these people. But to be sure, colorectal cancer of the colon everywhere whether in Asia, Australia, it is on the increase. And I think for a variety of factors, and I think this session is very worthy taking back and reflecting on looking at your risk factors. What is it I can do to mitigate them? And if so, if I happen to be having those risk factors, what is it I can do to help me to catch this cancer in an early stage? It's a tough one if you catch it late. So there's all the incentive for the investment to do this very, very, very early. So I'd like you to join me to thank the panelists who, by a big clap, who have been able to spend their time this afternoon to educate us on this very important subject. Thank you very much.
Can we give another round of applause? That was very, very educative. I had very many big words, you know, carcinoma, sarcoma, diagnostic pathway. How many of you have learned something today? Something, you know, interesting, something. I hope that what they have said, the most important thing that they've all said is that we need early diagnosis awareness. So I hope that we are not just listening, that we are taking it and we're going to use it. So thank you once again, all the doctors and professors who have given us the time and given us, you know, really good knowledge. We'd like to go to the next stage of our event, and I'd like to invite Angela, who will come. An event needs some celebration, some music, so we're going into that stage. And as she comes, I want to remind us that this is a cancer awareness event, but we're also buying a book. Who has bought a book? We need to see more hands. We need to buy the book, so please, the book is available. The ushers can help you if you'd want to buy one. It's 50,000 shillings. It's a really good book. I'd encourage each of us to go with a copy. You can pay cash, you can pay with Momo Pay or Airtel Money. That is available, so please make sure you get a copy. And I'd also like to let you know that the bathrooms, the restrooms, in case you'd want to go to the restroom, the bathroom, there is a short corridor there. You can go there, or you can go downstairs. There's also bathrooms, same area, but downstairs. So please feel free if you need to do that. So I'd like to invite Angela. You're welcome to the stage. Let's welcome Angela. Round of applause, Angela.
The song is God is too faithful and he's not leaving us halfway. The journey, he's still moving along with us. Be blessed. You were who you are yesterday, today and forevermore. What you say is what you do. You never fail, you never change. You were faithful till the end. Faithful God, I worship you. Oh, and you're too faithful to fail me. You're too faithful to disappoint me. You've proven yourself in my life and I've come to realize you're too faithful to fail me. You are too faithful, and you're too faithful to fail me. Oh, Jesus, you're too faithful to disappoint me. You've proven yourself in my life, and I've come to realize that you're too faithful to fail me. Oh, da 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 da, da 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 da, yeah, da 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 da. Oh, and you are yesterday, today, and forever. What you said, what you do. Oh, God, you never fail, you never change. You were faithful till the end. A faithful God, I worship you. And you're too faithful to fail me. God, you're too faithful to disappoint me. Too faithful to you never leave us alone. You've proven yourself in my life, and I've come to realize you're too faithful to fail. You're too faithful to fail me, God. Oh, you're bigger than all you can say. You're too faithful to disappoint me. No, God, I've come to realize, yeah, you're too faithful to fail me. Oh, you're too loving to leave me. Not in my pain. You're too loving to leave me halfway. And what you start, you always be. And I've come to testify that you're too loving to leave. Too loving, you're too loving to leave me. God, to leave, too loving, too loving, too loving. To love and to leave me halfway. What you start, you always finish. And I've come to realize that you're too late. Oh, too late. You're too faithful to fail me. Oh, Jesus, you're too faithful to disappoint me. You've proven yourself in my life, and I've come to realize that you're too faithful to fail me. And you're too committed to leave me. Oh, Jesus, you're too consistent to leave me halfway. And what you start, you always finish. And I've come to realize that you're too faithful to fail me. Oh, what you start, you always finish. Lord, I'm here to testify that you're too faithful to fail me.
Can we have a bigger round of applause? That was very beautiful. Thank you very much, Angela. Thank you. Okay, do we have those, for those of us who have our books, I'd like to do a very short reading. So could we please open to page 3 of the book? The preamble, really the third page, page 3 with Roman numeral 3. I'll just read a couple of paragraphs. I'll start with the first paragraph, but the last sentence of the first paragraph. On page 3, the preamble. The year was 2022, and I was in Belgium. I was 44 years old. Initially, I experienced mild rectal bleeding, an uncomfortable back pain, and a visibly altered change in bowel movement. These symptoms prompted me to go for a medical checkup. The journey following the discovery was rocky. I went through multiple investigations and examinations, including computer tomography, CT scans, endoscopies, colonoscopies, magnetic resonance imaging, multiple x-rays, and uncountable rounds of blood draws and examinations. I went through rounds of surgery, chemotherapy, radiotherapy, and lived with an ileostomy bag for almost 1 year. I experienced life-threatening circumstances, but I prayed, and many prayed for me as well. In the end, I overcame. Today, I thank God that He took me through it all. I have written my story as a service to humanity and source of encouragement and inspiration to many. I have also written it to demonstrate that fear, denialism, and stigma should not be given a place in the fight against this crippling disease condition. My story also attests to the fact that cancer is treatable and curable, especially when detected early. Ladies and gentlemen, the man who went through this is here. He lived, he survived, he's here to tell his story. And so I'd like to invite Dr. Geofrey Musinguzi to the official launch of the book.
That is for God, it's not mine. You're all welcome. Thank you so much for coming. So that was very interesting and lovely. I never expected it. Protocol observed. I know we have so many dignitaries in here. I want us to focus on the very important things that really brought us here. I want to really thank Prof. Rhoda. That was really a good preamble and opening. The panel, that was really excellent. This book has some jargon, some things in there, but I was trying to say, how can I simplify? So the panel like set a precedence towards some of those things. So when you read, they have talked about them. Some of them are in this book, but I gotta try and simplify them. But before I go to that, you know, for me, I say I'm a miracle, a living testimony. And because of that, I can't leave this place without glorifying my God, without really singing a song of praise and thanksgiving. And for that matter, I'm going to request you to stand with me as we sing this song. And this song will be led by one of our very own, one of the popular gospel artists. If I mention his name, most likely you all know him. Brian Luvega. Please come and lead us. Oh, he went upstairs, so he's coming down. Yeah, so yeah, but the truth of the matter is for me, I know when you read this